I'm Aaron. I'm one of the pharmacists with the Therapeutics Initiative. I also work with the hospital system in Fraser Health as a medication use evaluation pharmacist. And I was given the chance to talk to you about Portrait. So I'm in the twilight of my life. I'm 54. And this is where you're supposed to say you don't look a day over 40, but you missed your chance. I may not get over it. But so I've been doing a lot of self-reflection and wondering, will I ever grow up? Again, you could talk to my wife of 22 years, and she would say that it's highly unlikely, but I think there is a chance. So I gathered up some portraits of some of my colleagues, and they look distinguished and esteemed, like they actually have grown up. And then I looked at a portrait of myself from 2 weeks ago, and this is with my best friend. And we decided to do dumb things on mountain bikes. And then after that, thankfully we survived, we decided to go have dinner at Costco. And we chose hot dogs and fries, and we decided to eat them on the hood of my car in the parking lot. So I'm not so sure there's any hope for me. But at least it allowed me to reflect by looking at my colleagues and their portraits. And it's kind of analogous to what I think Portrait offers you. And so if you're not familiar with Portrait is a program we offer at the Therapeutics Initiative for family physicians and nurse practitioners in BC. It's free to you. And what it does is basically takes the above average prescriber, a picture of Jessica as the above average prescriber, but it would be any prescriber in BC that signs up for Portrait, and it takes her prescribing patterns and compares them to the average prescriber in BC. And what it does is it allows you to reflect specifically on your prescribing patterns, compare to other people like your peers. It's for your eyes only. So if you're concerned about who has access to my prescribing data and where does my comparison go, does it go to other people, to the college, to anything like that? It's very, very strict. The protocols that TI has to follow to be able to access PharmaNet to get your prescribing records is so intense that you can rest assured that it's only for you. We do about 2 to 3 topics per year, and we only pick topics where it's a common issue in BC primary care and the action that we're suggesting is possible. So you don't have to worry about, we're going to bring up issues that you probably won't see in your practice. You don't have to worry about issues like, I've got too much stuff going on. I don't need to be overloaded with another practice support tool. It's 2 or 3 per year. And finally, we supplement your Portrait with evidence-based recommendations. So if you're familiar with our therapeutics letter, each portrait comes with a therapeutics letter that describes what we suggest is optimal prescribing for that particular drug medical indication. So you're not left with questions like, I may not be doing what's perfect, but what am I supposed to do to improve? The letter within 2 or 3 pages outlines exactly what we suggest you do. And so when you look at your portrait, you're allowed to, or I think it enables you to ask a couple of questions or come up with a couple of responses. One of which is, if you're lower than the standard that's set by your peers or by the evidence, you might say, well, how could I improve and optimize my prescribing? But if you looked at your prescribing patterns and they're better than your peers or meeting the evidence standards, then I think that's a good way to reinforce your good behavior, so to speak. So it's useful in a variety of different ways. So we've had 9 portraits released-ish. We are also evaluating those portraits in terms of doing randomized control trials. Just to let you know, our recent portrait publication on urinary tract infection showed that there was a collective improvement in prescribing in BC as a result of being exposed to the portrait and the therapeutics letter versus not. So that is a nice thing, and we've seen that effect in multiple different portraits in the other studies that we've done. So in a very short time, I'm going to attempt to give you the highlights of most of the portraits that we've done so far. I've left out a couple for a number of reasons. If you're wanting to know the full scope, come talk to me after. But you can also go to our website and find out about this. And before I get into the highlights, I'll just remind you that if you're a prescriber in BC, a family physician or a nurse practitioner, and you haven't signed up for Portrait, Jessica and I will be at the table during lunch and after, and we can sign you up right away. If you choose to do it later, just one tip, when you sign up, use an institutional email address, not a personal email address, and that speeds up the verification process. It's part of the confidentiality agreements that we have with the Ministry of Health. So first, I tried to divide these up into themes. So these are not TI themes. They're what appeared in my head when I looked at the 8 or 9 different portraits. So this is under the softer touch theme, and it's our portrait on the first-line treatment for uncomplicated UTI. And our recommendation is to choose nitrofurantoin as your first choice. And why do we do that? Is it because the outcomes are better with nitrofurantoin? And that's not the case. In fact, what we see is the symptom resolution with nitrofurantoin is similar to other comparators, but what differs is the local resistance patterns. So what we see is despite nitrofurantoin use increasing, the resistance has remained stable, whereas the local resistance patterns for the other antibiotics is increasing. So for us, a good enough reason to suggest nitrofurantoin. Under the softer touch theme, the second one is about gabapentin and pregabalin. And Tom and I have a particular interest in this subject, and we've been, I would say, obsessed with these two drugs for many years. So this portrait's under I think the title is Finding the Lowest Effective Dose of Non-Opioid Analgesics or something like that. And a lot of the marketing around these drugs suggests that those drugs have the most impact when you try to attain a target dose of 3,600 milligrams of gabapentin or up to 600 milligrams of pregabalin. And in our review of all the clinical trials, there's what we call a ceiling dose, above which you're very unlikely to see a patient feel any better, but more likely for the patient to experience harm. And those ceiling doses are about half of what the target doses are claimed to be. So trying to get above 1,800 milligrams and expecting a patient to do better is unlikely, and trying to get to more than 300 milligrams of pregabalin and expecting a better outcome is also very unlikely. So other tips. Based on the pharmacology and the kinetics of these two drugs, if you try a change in dose, say you have someone above what we consider the ceiling dose, and you want to see what impact that will have on the patient, say going from 24 to 2,000 milligrams, because of the kinetics of the drug, those impacts will be seen within a week, probably within a few days. So long therapeutic trials of dose changes are unnecessary and probably irrational, which is liberating from your perspective and the patient's, because you'll know quickly if bad things are going to happen when you change the dose or good things, or there's no difference. The other thing to keep in mind about all of these non-opioid analgesics, gabapentin, pregabalin, duloxetine, venlafaxine, amitriptyline, at best, the number of people that will come back after a reasonable treatment course with any of them and say that I feel better is about 1 in 8. So set your expectations and the patient's expectations accordingly, that it should not be a surprise to you if people come back and say, I've tried it for the prescribed therapeutic trial and I don't actually feel better. Under the theme of do less, we have the long-term use of PPIs for GERD and dyspepsia. So Dee did a very good job of outlining the issues around proton pump inhibitors, and this is just a reiteration of some of the messages she had. So what we suggest is proton pump inhibitors are used commonly. They're used commonly beyond the recommended duration. And when you see a patient that's been on a prolonged PPI and it's time to renew, stop and don't renew. First, look for the indication. And if the patient has symptoms or intermittent symptoms, instead of a regular prescription for a PPI, consider either stopping or using an as-needed prescription. And why do we say that? And Dee mentioned this, is that long-term exposure to PPIs is not without risk. And in my practice in the hospital, my sense is that there's this sort of belief that PPIs are relatively harmless. And our recent review of the evidence of long-term exposure to PPI suggests that that is not the case. So it's at least every year for a patient on a PPI, reassess the need and potentially stop or use PRN, and it's because of the long-term exposure risks that we're really concerned. Under the theme of do less, again, we have our portrait on inhaled corticosteroids for patients with COPD. So in that case, what we're suggesting is that for most patients, so for mild or moderate COPD, we suggest that inhaled corticosteroids are likely to increase the risk of harm without having a meaningful impact on symptoms or reducing the risk of exacerbations. So very little advantage or no advantage, but likely to increase harm. Now, for most patients, A combination of long-acting bronchodilators seems to be better than adding an inhaled corticosteroid. And keep in mind the implications of that in terms of the recommendations to move toward triple therapy inhalers and how that, according to the evidence, we're suggesting that it looks like there's probably a subset of patients that might benefit from triple inhalers, those that have frequent exacerbations, frequent hospitalizations, trouble with symptoms on bronchodilators that aren't resolving. There might be that small subset that you might want to try a triple inhaler, but for the mild to moderate COPD patients, that extra drug in the form of a corticosteroid is likely to cause more problems without improving the symptoms. And then along the lines of do less, we have our recent portrait on elderly patients with type 2 diabetes. And there are a number of important messages in that portrait. I've only highlighted one, which is if you have an elderly patient with type 2 diabetes and their A1C is already at 7 or lower, and they're on insulin or sulfonylurea or both, that's a really good target for you to say, maybe I can back off. So one of the messages that I don't get into today is that lower A1C targets less than 7 in this population is not known to be beneficial. And so you can back off. If you're already at below 7, get rid of the drugs that are known to be harmful, which are the insulin and the sulfonylureas. So those two drugs in combination or individually will increase the risk of severe hypoglycemic episodes, and they add no value in terms of cardiovascular benefits. So really good targets for deprescribing. In terms of avoiding low-value care, we have a portrait on bisphosphonates. There are a number of messages in there. One is that in patients that have had a fragility fracture, there may be some impact on fracture risk, subsequent fracture risk. So in secondary prevention patients, there may be some value for bisphosphonates. But for those people that have never had a fragility fracture and are under screening, been classified as having osteoporosis, there's no notable reduction in the risk of fractures. And what about population screening? So what we know is that population screening with FRAX scores plus or minus DEXA scans doesn't amount to a decrease in the risk of fractures in a population. So intuitively, you would think that if I identify someone that is supposed to be high risk, that sets into motion a series of actions like exercise regimens and drug treatments. And overall, if you catch that high-risk person early, that it should lead to a population reduction in fractures, and it doesn't. And there's one interesting study that looked at BMD testing and its ability to predict which postmenopausal women will have fractures. And postmenopausal women that have low BMDs, normal BMDs, or high BMDs seem to have the same risk of hip fracture. So that tells you something about the predictive ability of BMDs. So it's not a really useful thing to screen everyone just in case. Another point about avoiding low-value care is statins. And if you followed the TI for a number of years, you know we have a few opinions about statins. One of them has been consistent all along, is that the evidence for statins in primary prevention is different than the evidence in secondary prevention. So those with existing cardiovascular disease, statins behave differently in them versus someone that has risk factors. And especially in the elderly, we reiterated our previous statements that there's no reduction in premature death, stroke, or MI risk in primary prevention elderly patients that are prescribed statins. So you wonder, how common is this? Anyone want to take a guess at how many people over 70 on statins fall into this category? A lot? Yeah, it's 68%. So the majority of patients over this age that are on statins fall into this category. So when I said we pick portraits where there's a common issue, this is one of those ones where it's quite common. And then I think this is the last one, to do more, actually. So when you're talking about a patient with high blood pressure and you've started a thiazide diuretic, as Dr. Wright suggests, and that's not quite doing it, and you're looking for a second-line option, we suggest choosing ACE inhibitors over any other class. And if you're choosing between ACEs or ARBs, we suggest choosing ACE inhibitors because, as Dr. Wright pointed out, that the evidence for ARBs is lacking. We have lots of evidence for ACE inhibitors and very little for ARBs, so it would be the preferential choice. If you're concerned about cough and discontinuation due to cough, as far as we can tell, about 1 to 3% of patients stop ACE inhibitors due to cough. So it does happen and it's relatively rare, so it might be the first thing to try. So just a quick summary, how can Portrait help you? I think there's a couple of ways. It's a very simple way to self-reflect on your prescribing practice for 2 or 3 common issues in primary care in BC each year. It is a way to at least learn about the best evidence and try to find ways to implement it in your practice. And I think overall our experiments have shown, and you could probably realize just by listening to the talk, is that it's a collective effort to improve prescribing in BC. And so far we've shown consistent impacts on that. We're not the only people doing this kind of work. Audit and feedback, another way to describe what we're doing in Portrait, has been utilized in a number of different jurisdictions and studied in similar ways. And the evidence is relatively consistent that audit and feedback given to prescribers shifts prescribing, and usually in a positive direction. So we suggest it's the way to go. Now, getting back to me and my self-reflection, I don't think I ever want to grow up. I actually want to go backwards. So this is a picture of me in preschool, and I think I'm headed there instead of forward. So thank you for listening. We have a few minutes for questions or comments.
What's your thought on using the nebulizer versus the powder, the MDI versus the
dry powder inhaler?
Yeah, dry powder inhaler versus for environment purposes. And
what's my comment on that?
Yeah,
so
because it does have an impact on environment, I think. Right?
It does, yeah. So if you're talking about salbutamol as a rescue inhaler, there is a reasonable alternative called terbutaline, which is a dry powder inhaler. And it's not without its own problems. It comes with packaging and plastic. But at least terbutaline doesn't contain a propellant. So if you talk about the carbon impact of terbutaline, it's equivalent to driving a gas-powered vehicle about 3 kilometers. The same for the best version of salbutamol generic is 33 kilometers. So Bricanyl is available and is covered by pharmacare. It's slightly more expensive by unit cost, but when you consider if you were to buy a spacer, that the costs are not that different. And the other advantage of terbutaline inhalers is the expiry date's 3 years. So if a patient's using it intermittently, it will last much longer than a salbutamol inhaler, which is at best about a year. Any other comments?
Yeah, you mentioned the elderly. Of course, I'm one of that group. But the category you're using is over 70. But the elderly, in fact, is an enormous group and getting bigger, as we know. Mm-hmm. And so there's 2 categories, really. I guess it's going to be the elderly, the very, very elderly, all of whom I take care of. So when you talk about referring to that group, I would think that discriminating between them would be important. One of the problems is, though, that the studies, there are very few paucity of studies that of the very elderly mm-hmm. and how it relates to a medication, et cetera. So I just wondered about your comment about that.
Yeah, that's a great comment, and I apologize for the oversight. And we drew that line for statins because of the kind of people that were studied. And you're correct in that the statins, the representative of the very elderly in statin trials is low to non-existent. So the best information we have is the people over 70, but not over the very elderly threshold, which would be about 80, Dr. Wright? Yeah. So I don't know if I answered your question other than you're right that with statins and many other medications that the kind of people that get into those trials are not usually over 80. So we don't know anything about how they behave. Yeah, I like that at your own risk. I think it's a evidence-free zone. So I don't know what to say other than the best information we have is people between 70 and 80. And beyond there, we really don't know. I mean, the benefits might persist in that age category or the harms might start to outweigh the benefits after 80. But I don't know. So there's a question online about any role of switching PPIs to H2 blockers. And I think in our portrait, we recommend that is a reasonable strategy, that the risk of harm from long-term exposure is probably less with H2 blockers than it is for proton pump inhibitors. Is it worth trying gabapentin if pregabalin trial fails and vice versa? So probably not, but there's a really interesting paper that Tom Perry referred me to. It's called Pursue Analgesic Success, Expect Failure. And it's a very interesting paper. If you want to read it, let us know and we'll send you a copy. It's written by one of the members of the Oxford Pain Group. And basically his conclusions are that it's very difficult to predict the likelihood of success when you've had failure from other agents. So there's no studies and there's no real way to know if I do poorly on one, can I switch to another, and does my likelihood of benefit increase? So we don't know. I think it's reasonable to try if a patient's willing to try, but based on the kinetics, what we would suggest is a rational, short therapeutic trial is probably all that's necessary. And for pregabalin and gabapentin, when we looked at the studies, Tom and I and our students, and in the studies that report pain score reductions, but pain score reductions, and if they report it by day, the biggest drop or change in pain with gabapentin and pregabalin and duloxetine happens in the first 72 hours. So it's not like a patient needs to take it for days or weeks to know. If they don't feel anything or they feel worse in 48 hours, that's probably going to tell you they're not going to respond to that drug.
At what GFR do you stop using nitrofurantoin, and what do you use as an alternative for UTI?
Jessica, can you answer that question?
So the question was about the GFR, probably 30. You could probably use it at lower than that, but that's as far as it's really been looked at. And we are, with the support of the BC CDC, recommending phosphomycin single dose as an alternative. It's a bit more expensive. We may be causing more resistance in the future with that, but it's what the BC CDC, Do Bugs Need Drugs, feel is the most appropriate because it's so much safer than the Cipro, the other alternatives. That may change in a few years. There's a lot of debate about that, but that's what we're recommending for now.
Thank you, Jessica. Tom, I'm going to need your help with this question from online. Do specialists agree with the recommendations from Portrait? Specifically, they're asking about the COPD and inhaled corticosteroids Portrait. So I know you have some insight based on who peer-reviewed the letter that supported the Portrait. Do you want to comment on that?
Yeah, it's very complicated. It was pointed out to us, and I think we posted it under a comment under our letter, that the 2023 Canadian Thoracic Society guideline was much more enthusiastic about inhaled corticosteroids for COPD, global outreach for lung disease. And the lead author of the Canadian guideline is McGill University. He sent us some information with the numbers needed to treat that are cited in the Canadian guideline cannot be verified. They haven't been published. They may be part of the clinical trial study reports, but we've been unable to sort that out. So we're still trying to look at it. And I think the practical thing for me, if somebody has, as an internist, if somebody had complicated chronic lung disease and the respirologist has said, I really think they need this stuff, am I going to argue with them? No. But if I were starting treatment on somebody with COPD, having persuaded them to stop smoking and to exercise more and to avoid allergens or air pollution, et cetera, personally, I wouldn't start an inhaled corticosteroid. That's how I'm confident we got the evidence right there.
Thanks, Tom. And Wade, I'm going to lean on you for this question. What is your recommendation for targeting LDL levels with a statin post-acute stroke in someone over 85? So nice and simple question.
I don't know.
Great. Do you want to add a little bit more detail?
I mean, there's no evidence. I don't think we'll ever know. I think probably going based on available evidence, you would say use like a high intensity statin, but in someone who's over the age 85, that may not necessarily be tolerated. And again, there's no evidence. So I think, you would be potentially, it could be reasonable depending on the person to try high intensity statin and see what happens. But I think you could be happy with a low or moderate intensity statin in that scenario. I think just being on a statin is going to give you the most bang for the buck versus targeting a specific LDL.
Okay, great. Thanks,
That's the
Wade.
best I can say.
And just to add, if you haven't read the Simplified Lipid Guideline put together, I think it was published in Canadian Family Physician by some of our friends in Alberta and BC. It's a really sensible look at management of hyperlipidemia and the use of statins, and they comment a lot about targets. So without getting into the debate and our opinions on LDL targets, I'd refer you to that. It's a really interesting take, and I think a sensible approach to that question in the elderly and the non-elderly.